Here I will talk about different immune disorders, their mechanisms of pathogenesis, as well as their clinical symptoms. So first I will fill in this table, and then in the end I will summarize all the findings. The first condition I would like to talk about is Wiskott-Aldrich Syndrome, which is due to mutations in the WAS gene. So mutation in WAS gene, which is required for actin cytoskeletal remodeling. So due to the defect in actin cytoskeletal remodeling, there is impaired function of T cells. So T cells will not be able to interact with other antigen presenting cells, and they would not be able to migrate or adhere to other type of cells. So therefore these patients present with the triad of recurrent infections, eczema, which usually coincides with a superinfection, and thrombocytopenia that is immune related and is due to the decreased volume of platelets. So these patients present with easy bruising and petechia due to thrombocytopenia. The next condition is Ataxia-Telangiectasia, which is due to mutation in the ATM gene. So Ataxia-Telangiectasia mutated. An ATM gene is required for DNA repair, and since DNA repair is required in almost any tissue, there are multiple different tissues that are affected in these patients, and thus they present with a variety of different symptoms. So as the name implies, these patients present with cerebellar ataxia, inability to coordinate head and eye movement while shifting gaze, recurrent infections, which are usually sinopulmonary infections. And there are two reasons to that. One is due to decreased IgA, and the other one is due to the aspiration, which is related to the neurological problems that is present in these patients. And finally, these patients present with telangiectasia. So telangiectasia in these patients is usually oculocutaneous. So if this is the eye, they would usually present with dilated vessels on the side of the eye like this. One other last point that I would like to mention, so you know how I said these patients present with sinopulmonary infections due to IgA deficiency. So how I memorize it is ataxia starts with the letter A, so there is decreased levels of IgA in these patients. The next condition is Bruton agammaglobulinemia, which is due to mutations in the Bruton tyrosine kinase gene. So Bruton tyrosine kinase gene. And this gene is required for maturation of B cells. So if there is problem with this gene, then there would be impaired B cell maturation, as a consequence of which there would be decreased immunoglobulin of all types. And the other presentation is there is no circulating B cells in these patients. Now, some students confuse Bruton agammaglobulinemia with common variable immunodeficiency. And I would like to mention that although the presentations may be similar in these patients, there are some critical differences that can help you identify these two disorders from each other on the exam. So CVID is also due to impaired B cell maturation, as a consequence of which there is decreased immunoglobulin production. However, unlike Bruton tyrosine kinase gene that is mutated in Bruton agammaglobulinemia, CVID is due to mutation in multiple genes, and thus their presentations is variable. So the symptoms as well as the age of onset is variable in these patients. Also, most of these patients usually present with normal number of circulating B cells. So just keep in mind that CVID is due to multiple mutations in different genes, presentation is variable, and there is normal number of circulating B cells, versus Bruton agammaglobulinemia, which is due to mutation in the Bruton tyrosine kinase gene, and there is no circulating B cells. The next condition is Chédiak-Higashi syndrome, which is due to the problem in the LIST gene, so LIST gene, that is required for the protein trafficking of the organelles. So consequently, due to the problem in the protein trafficking in these patients, they would present with peripheral neuropathy, giant granules that are present in the neutrophils and T cells. So if you have a neutrophil right here, and this is like the nucleus, something like this, then we would have giant granules that are present in these neutrophils. And the problem is that these granules cannot be released during the time of invasion by bacteria or the virus, and thus there is immune problem in these patients. The other problem is neutropenia. So since there is problem with the protein trafficking, there is also a problem with cell division, and thus these patients present with neutropenia. And finally, there is partial albinism. So therefore, there would be enlarged pigment granules which contain melanosomes inside the melanocytes, and thus these melanosomes cannot be transferred to the keratinocytes or the epithelial cells. So these patients present with partial albinism. And what I mean by partial albinism is, let's get a clear page here. So if this is the face, and there are all black hairs that are right here, there would be some strands that would be white. So it would be something like this. So it won't be complete white. So it would be a mix of normal hair color and white colors due to the albinism. The next condition is Hyper-IgM syndrome. And this syndrome is due to the defective CD40L on helper T cells. So here I would like to go over the mechanisms that B cells become activated. So there are two mechanisms through which B cells can become activated. The first mechanism is when the antigen is presented to the IgM or IgD receptors on the B cells. So when this happens, these B cells will become IgM producing plasma cells. The second condition is when B cells consume the antigen and they present it via the MHC2 receptors to the T cell receptors on the Th cell. So let me draw that for you. So here we have a B cell, and then we have a Th helper T cell here. So B cell via the MHC2 receptor will present the antigen to the helper T cells. So this is a T cell receptor here, and here it's the MHC2 receptor right here. And when this happens, in response, CD40 ligand of the helper T cells, so CD40L, will interact with the CD40 receptor of the B cells. And through these two signalings, the first signal and the second signals, B cells will undergo class switching and can become plasma cells that produce IgA, IgG, and IgE. So if there is problem with the CD40L in this patient, so this part is missing. So what happens is that neither IgA nor IgG nor IgE will be produced. And thus the only mechanisms through which B cells can become activated is through increased production of IgM. So let's go back to the table. So these patients present with increased IgM, but decreased IgA, IgG, and IgE. The next condition I'm going to talk about is severe combined immunodeficiency, or SCID, which can be caused via two different mechanisms. The first mechanism is due to deficiency in the adenosine deaminase, as a consequence of which the toxic material will build up in B and T cells and cause their death. And the second condition is IL-2 deficiency. And IL-2 is required for the activation of B and T cells. So via either one of these two mechanisms, both B and T cells will be defective in these patients, and thus they would present with recurrent diarrhea as well as fungal infections. The next condition is IL-2 receptor deficiency. So as a reminder, IL-12 is required for the differentiation of helper T cells into Th1 cells. So Macrophages are the molecules that release IL-12, and once they do that, they induce the differentiation of CD4 T cells into Th1 cells. And in response, Th1 cells will release interferon gamma, which induces the differentiation of macrophages into epithelioid histiocytes. And these cells are required to block off the mycobacterium. So if there is problem with the IL-12 receptors, therefore interferon gamma will not be released and macrophages will not be able to differentiate. So these patients will present with disseminated mycobacterial infections. So disseminated mycobacterial infections. The next condition is chronic granulomatous disease, also known as CGD, and it's due to the problem in the NADPH oxidase. So let me get a blank page for you here. So as you know, NADPH is required for the process called respiratory burst. And through this process, oxygen will be converted via NADPH oxidase into superoxide. And the superoxide is used by the neutrophil to kill bacteria. Now, if cells lack NADPH oxidase, then they wouldn't be able to produce superoxide. However, there are some bacteria that are producing oxygen radicals, and thus white blood cells will use those oxygen radicals still to kill the bacterium. The problem arises when there are pathogens that contain the enzyme catalase, and catalase will break down H2O2 into water and oxygen. And thus, white blood cells will no longer be able to use H2O2 to kill the pathogens. And thus, patients with NADPH oxidase deficiency are particularly prone to infection with catalase-positive organisms. And these organisms include, I use the mnemonic space, Staphylococcus, Pseudomonas, Aspergillus, Candida, and E. coli. Now, there is one important test that you should be aware of, and that is used for diagnosing NADPH oxidase deficiency, and it's called the NBT test, or nitroblue-tetrazolium test. And what happens is that PMNs convert NBT into formazine via the NADPH oxidase. And this formazine has a blue color. So what happens is that any cells, any PMN cells that have normal functioning NADPH oxidase will present it with a blue cytoplasm, also known as a positive or normal test. Versus those cells that lack NADPH oxidase will present with a colorless cytoplasm, and that would be a negative or abnormal test. So just be aware of the concept of the NBT test. Now let's go back to the table and continue where we left off. So again, chronic granulomatous disease is due to defects in the NADPH oxidase, and these patients are particularly prone to infections with the space organisms, which are catalase positive. The next condition is leukocyte adhesion deficiency, which is due to the problem in the LFA1 integrin protein, also known as CD18. And that's important, CD18. So integrins are generally required for adhesion of leukocytes to endothelial cells. So what happens is that when there is problem with the LFA1 gene, leukocytes will not be able to accumulate in the sites of inflammation, as a consequence of which these patients will present with recurrent infections that have no pus formation. So pus are dead leukocytes that are formed at the site of inflammation. But if leukocytes cannot go to the site of inflammation, therefore there will be recurrent infections without any pus formation. The other presentation include the neutrophilia, So the body knows that they're being attacked by pathogens, and thus they would increase production of neutrophils. But if neutrophils cannot get out of the peripheral blood and they just stay there, what happens is that once you do a blood count, you see that there is an increase in the count of neutrophils, but then they wouldn't be able to go to the extravascular sites of inflammation. And then finally, these patients present with delayed separation of the umbilical cord. So normally umbilical cord on average separates 10 days after birth. In these patients it takes longer than 30 days. And that would be another sign of leukocyte adhesion deficiency. The next condition is Job syndrome, also known as Hyper-IgE syndrome, which is due to mutation in the JAK-STAT gene, as a consequence of which there is impaired function of helper T cells, which interferes with PMN chemotaxis. And since there is problem with the PMN chemotaxis, these patients present with cold, also known as non-inflamed abscesses. At the same time, in response to the pathogenic infections, there would be increased production of IgE, which activates the mast cells, and they would release the histamine. And histamine can cause pruritus and eczema in these patients. In addition, there are other facial problems such as broad nasal bridge, retainment of the primary teeth, as well as coarse facial features. Now, I understand that it may be hard to memorize all these symptoms for IgE syndrome, also known as Job syndrome. So here I have come up with a memory aid that can help you memorize the symptoms. So let's imagine we have a face with coarse features. So that's the first thing, a face with coarse features, a broad nose and retained primary teeth. So broad nose and retained primary teeth. Under here I'm going to put 2S for ears, which means there are staphylococcus abscesses in these patients that are usually non-inflamed. And finally, there are eczemas that are present in these patients. So just remember this face, and you can recall that there are broad nose associated with these individuals, coarse facial features, eczema, retained primary teeth, and staphylococcus abscesses. Now let's go back to the table again and continue where we left off. And the final condition is selective IgA deficiency. And so you know IgA is protecting the GI and the sinopulmonary mucosal surfaces against infections. So since there is problem with IgA production in these individuals, therefore there would be recurrent infections with Giardia lamblia. And there would be also sinopulmonary infections such as otitis media, sinusitis, and pneumonia. Another feature of IgA deficiency is anaphylactic reaction in response to the blood transfusion. And when you transfuse these individuals with a blood that contains IgA products, the antibodies that are already present in these patients will attack IgA and cause anaphylactic reaction. So now I would like to go over this table and quickly summarize the findings. So Wiskott-Aldrich syndrome is caused due to mutation in the WAS gene, and it results in defective cytoskeletal remodeling of the actin filaments. And thus these patients present with a triad of recurrent infections, thrombocytopenia due to decreased volume of platelets, and eczema that usually presents with superinfections. Ataxia-Telangiectasia due to mutation in ATM gene, which is required for DNA repair. And since DNA repair is required in every tissue, there are multiple organs that are affected in these patients, including the cerebellum that causes ataxia, saccadic eye movements, telangiectasia of blood vessels, which usually present on the side of the eye, like dilated vessels like this, and recurrent sinopulmonary infections due to IgA deficiency. So again, ataxia starts with letter A, so it causes IgA deficiency. One other reason that these patients also present with recurrent sinopulmonary infections is aspiration pneumonia, and the reason for that is that since there is neurological problem, they usually aspirate, and thus it causes aspiration pneumonia. The next condition is Bruton hypogammaglobulinemia, which is due to defective function of Bruton tyrosine kinase gene, which is required for the B cell maturation. So since B cells do not undergo maturation in these individuals, there is no circulating B cells, as well as lack of all immunoglobulins. The difference between Bruton hypogammaglobulinemia and common variable immunodeficiency disorder is that CVID usually presents with a variable age of onset and variable presentations, and it's caused due to mutation in multiple genes. And one final main difference with CVID is that there is normal number of circulating B cells with CVID. Otherwise, CVID has similar features in that there is lack of B cell maturation in these individuals. I would also like to remind you that Bruton hypogammaglobulinemia as well as Wiskott-Aldrich Syndrome, these two are X-linked disorders. So just keep that in mind. The next condition is Chédiak-Higashi syndrome, which is due to the problem in protein trafficking due to mutation in the lysosomal trafficking regulator gene, also known as LIST. And thus these patients present with recurrent pyogenic infections, peripheral neuropathy, partial albinism, and finally presence of giant granules in the neutrophil. So neutrophils and T cells would not be able to release granules, and thus they would start to accumulate giant granules. At the same time, melanocytes would not be able to release their contents, and thus melanosomes start to build up and would not be able to be transferred to the epithelial cells as well as keratinocytes. So it also causes albinism. So you can see that the problem is with the release of granules that causes all these different issues. The next condition is Hyper-IgM syndrome. So as we discussed, there are two different mechanisms for the activation of the B cells. The first mechanism is through the binding of the antigen to IgM or IgD receptors, as a consequence of which there would be increased production of IgM. And the second mechanism is through the MHC2 receptor, where the B cells present antigen to the helper T cells, and then helper T cells via the CD40L ligand will activate B cells. And these activated B cells will form into plasma cells that can produce IgA, IgG, and IgE. Now, if there is problem with CD40L, then there would be no production of IgA, IgG, or IgE. But the other mechanism of B cell activation is still intact, so there is increased production of IgM. The next condition is SCID, where there is defect in both B and T cell function. And it can be either due to the problem with the adenosine deaminase gene, where toxic material will build up in B and T cells and cause them to die, and the other possibility is defective IL-2 receptor, which is required for the activation of the T and B cells. So since there is complete lack of B and T cells, these patients will present with recurrent diarrhea and fungal infections and germinal centers in lymph nodes. So if you had a lymph node in the peripheral cortex, we had all these follicles, and at the centers we had activated mature B cells, and they were called germinal centers. So germinal centers would be absent in these patients because B cells cannot undergo maturation. And at the same time, thymus is the site of maturation for T cells. So since there are no T cells either, there is the absence of thymic shadow in these individuals. IL-12, as we discussed earlier, is required for the activation of helper T cells, as a consequence of which they would produce interferon gamma, and then interferon gamma will act on macrophages and help them differentiate into epithelioid histiocytes. And these cells are required to block off the mycobacterial infection. So if there is problem with the IL-12 receptor, then there would be disseminated mycobacterial infections. CGD is due to mutations in the NADPH oxidase, and these patients are prone to infections with space organisms which are catalase positive, and these include Staphylococcus, Pseudomonas, Aspergillus, Candida, and E. coli. The test that we are using to detect NADPH oxidase deficiency is called NBT test. Leukocytes adhesion deficiency is due to mutation in the LFA1 integrin gene, also known as CD18, and these patients present with neutrophilia. So since neutrophils cannot go to the site of inflammation, they would keep building up in the peripheral blood, and thus there would be neutrophilia. Recurrent infections without pus formation. So these patients, since there are no neutrophils at the site of inflammation, present with recurrent infections. But again, pus is the accumulation of dead leukocytes, and since there is no white blood cells at the site of inflammation, therefore there is no pus formation. And finally, delayed separation of the umbilical cord is another sign of leukocyte adhesion deficiency. Hyper-IgE syndrome, also known as job syndrome, is due to the problem with the chemotactic stimuli required for the PMNs. And let's go back to the mnemonic that I've shown you earlier, so that we can discuss the features of this disorder. So these patients present with coarse facial features, broad nose, retained primary teeth, Staphylococcus non-inflamed abscesses, as well as eczema. So there we go. These patients will have increased IgE, retained primary teeth, cold Staphylococcus abscesses, leonine faces, as well as eczema. And finally, selective IgA deficiency. So IgA is required for the protection of the mucosal surfaces in the GI and the pulmonary tract. So therefore, due to the lack of IgA, these patients are prone to infection with Giardia lamblia, as well as recurrent otitis media or sinusitis or pneumonia infections. Finally, since there is no IgA in these individuals, their immune system will start to form antibodies against IgA. So if you transfuse patients that lack IgA with a blood product that contains IgA, then the antibodies will attack the IgA that is in the transfused blood and causes anaphylactic reaction. So anaphylaxis due to the IgA containing blood products. And that concludes our discussion.